السلام عليكم. اولا المايك مش شغال. السلام عليكم. بشكر الدكتوره لبنى طبعا على التقديم، وفرصه سعيده ابقى مع اصدقائي واصحابي. بشكر اورجنايزنج كوميتي الدكتور خالد، الدكتور مصباح، الدكتور عادل، وجميع المشاركين في اليوئيدا. انا هتكلم برضو بسرعه على another facet of diabetic complication which is diabetic kidney disease. وانا حاطط التايتل chronic kidney disease not diabetic kidney disease لان there is no difference now between both diseases. It is very common. Chronic kidney disease is very common في الميدل ايست. عندنا من 7 ل 14% per 100,000. واهم سبب renal failure worldwide is diabetes. Almost 40% of those on dialysis due to diabetes. However, this is not the situation in the Middle East, not in Egypt. Why? Diabetes come in the third cause of kidney disease in Egypt or end-stage kidney disease. Why? Because of this link. There is a great link between diabetes, chronic kidney disease, and the cardiovascular disease. They are both stimulated or affected by the RAS system, by the neurohormonal sympathetic system, inflammation, endothelial dysfunction, ischemia, or fibrosis, and they both lead to each other, and they both will decrease the lifespan of the patient. That's why our patients في مصر ما بيوصلوش dialysis. They die early before dialysis. عشان كده في مصر hypertension is still the first cause of end-stage kidney disease. And this is the Egyptian renal data system showing that diabetes is the third cause. It's not even the second. Why? Because these patients never reach dialysis. They never reach dialysis or transplantation. They die of their heart. أحد المشاكل الكبيرة اللي بنشوفها في diabetic kidney disease في chronic kidney disease is the late diagnosis. Patient with stage 1 and 2, as you see, they have no symptoms. They have no abnormal lab finding. And also they are not seen by nephrologists. They are seen by diabetologists, cardiologists, general practitioners. So we don't treat this patient. We don't prevent chronic kidney disease as early. This is very bad. According to this graph in the United States, showing that although most of our CKD patients have grade 3 nephropathy, the awareness is very low. يعني العيانين عندهم chronic kidney disease and they don't know, and the treating physician is not knowing إن عندهم chronic kidney disease، وده اللي بيخلي البروجريشن والبريفنشن صعب. عشان كده برضه هتكلم زي ما الاستاذ دكتور فريد قال والدكتور ممدوح قال screening. We have to screen especially in first and second stages. Screening is very easy. ما هوش complicated زي ما سمعنا هوقف عين واقعد واعمل له فالزالفا. لا، أنا بس هعمل EGFR based على creatinine and age، وهعمل albumin creat ratio which is very easy and very cheap. And this will categorize our patient into different stages of chronic kidney disease and different stages of proteinuria. And we need to screen repeatedly every year لو هو في الأخضر أو في الأصفر. لكن لو البيشنت ترى الألوان تغمق I have to repeat screening twice or thrice or 4 times per year. And I have to refer the patient to nephrologist whenever his GFR is below 60 with proteinuria or below 45 without proteinuria. This is how to prevent chronic kidney disease in diabetics, because it is very difficult afterward to treat. And then we have to talk about how to manage these patients. Management or treatment until 2012, this is the KDIGO guideline 2012, stating that it's just protein restriction, salt restriction, lifestyle, exercise, and we might have some vitamins added to our patient. And not before 2020, when the KDIGO produced its first diabetic kidney disease guideline, and it insisted that we need to treat the patient as a whole, from nephropathy, cardiovascular disease, to prevent death of the patient, not just development of chronic kidney disease. And this was produced. How to treat chronic kidney disease? We have indirect ways and we have direct ways. Indirect ways اللي هو I have to adjust، لازم أضبط hyperglycemia, hypertension, and the volume status of the patient. And we have directed or target kidney treatment. Now we have available medications that can target GFR progression and also proteinuria progression. والأدوية اللي موجودة هي اللي ظهرت في الكيديجو guideline 2022, which will be produced next month. We have 4 first-line treatment to prevent progression of diabetic kidney disease. Metformin, if it is allowed, sodium glucose transport inhibitor, RAS blockade, and statin. These are directed against progression and against proteinuria. And we can also use GLP-1 and non-steroidal MRAs as a second line to prevent the progression to end-stage kidney disease and to treat proteinuria. And by this, we have now evidence that we can control and prevent CKD. Also, one of the very important guidelines, we have to strictly control blood pressure. According to this study, patient might lose 9 years of his CKD progression if his blood pressure is above 140/90, and we have to target blood pressure systolic less than 120, and it is recommended to use RAS blockade, ACEs and ARBs and MRAs. Why? Because over the past 20 years, we have a number of studies that showed evidence that RAS blockade has good effect on diabetic kidney disease as well as in non-diabetic kidney disease. But those who have very successful trial and the approval for treatment are only the Nile, the Micro Hope, the IDENT, and the RAIN study. They have very profound effect in progression of chronic kidney disease. And although these studies, especially the Nile study and the IDENT study, showed up to 20% regression of chronic kidney disease, they have a lot of residual risk and they are not addressing mortality. That's why the next line management was the introduction of finerenone. Finerenone is dihydropyridine mineralocorticoid antagonist, and it has very good effect in patients with diabetes and kidney disease. It reduces proteinuria significantly, and it reduces mortality significantly in patients with chronic kidney disease. And this is a Fidelio and the Figaro study, and it will be coming to Egypt soon. And even other mineralocorticoids. This study was done on eplerenone and spironolactone, and it would show also that it will regress progression of chronic kidney disease with the use of other RAS blockade. And the GFR difference is quite different between the two group of patients. يبقى ممكن نستخدم eplerenone, spironolactone في البيشنت with CKD to retard progression. And then we have the particular anti-diabetic medication that can prevent progression to end-stage kidney disease. These include the first line is sodium glucose transport inhibitor. Once it was introduced in 2015, we found that it's not just anti-diabetic medication, it is a cardiovascular protection medication. It reduces proteinuria, it prevents inflammation, it has very good effect on oxidative stress, it improves kidney blood flow, and among other things like weight reduction and every other thing. And this has proved to have beneficial effect on the kidney, on diabetes, as well as on the heart. And through all the studies, starting by the MBREG, ending in the EMPEROR study and the VERTIS study, they have showed significant reduction of worsening of kidney function in patients with diabetes and in patients without diabetes from the lab, heart failure and CKD, and we are waiting for the EMPA kidney soon. Also, they have the same effect on the heart. So they can use now drugs to protect the kidney and the heart. And in the last ESD statement last Saturday, they also insisted that the first line of treatment in patients with chronic kidney disease and diabetes is sodium glucose transport inhibitor, followed by GLP-1 to prevent progression to end-stage kidney disease. And that's why in this statement, they agreed for the first time with what KDIGO have presented in last March, that we can start sodium glucose transport inhibitor with GFR 20. It's not yet approved by the EDA, but the ESD statement said 20 last week. So we are now in agreement to use sodium glucose transport inhibitor in all patients with chronic kidney disease, either diabetic or non-diabetic. This was followed by GLP. GLP has a profound effect on proteinuria. It has anti-inflammatory effect. It can reduce glomerular injury, especially in the podocyte, and also it has some indirect effect. Blood pressure reduction, weight reduction, very good glycemic control, and so they are very beneficial for our patients. And revising all GLP receptor agonist cardiovascular and renal effect, we'll find also starting from, except maybe ELEXA study, they all have reduced proteinuria and good effect on the kidney. And also they have very good effect on the total renal endpoints, mainly in proteinuria reduction. And they are also very good for heart failure and for major adverse cardiovascular events. So we can achieve, again, protection cardiovascular and renal. And recently adding dapagliflozin to MRAs like eplerenone, in this very recent study, have shown that they have profound effect on reduction of proteinuria in patients with diabetic kidney disease. In any age, 6 type of diabetes, GFR, urea accession ratio, body mass index, they are very effective adding it together. And there is another study on the use of finerenone with dapagliflozin again to prevent proteinuria in patients with diabetic kidney disease. We should mention that it is not just diabetes, it's not just hypertension. We have to add statins to all patients because it is life changing. It can reduce the incidence of heart failure and the major adverse cardiovascular event, and they may have some beneficial effect on the kidney. Patients should stop smoking because even in passive smokers, there is increased risk, 60% more risk of developing chronic kidney disease with smoking. Of course, obesity is now a target of treatment. And thank you, diabetologists, because they produce medication that can reduce weight, control diabetes, help the kidney, as I will show you in the last few slides. And also, diet should be one of the prime target in our patients. We have to educate the patient. And finally, we have the tirzepatide, which has now shown to be very effective anti-diabetic medication and weight reduction medication. And also, this is a very recent study just published 2 weeks ago in the Lancet showing the good effect of tirzepatide on chronic kidney disease. So it is expected to work in chronic kidney disease in the same beneficial way that sodium glucose and GLP-1 is produced. And it slowed the progression of chronic kidney disease in patients with type 2 diabetes. And now we have a lot of FDA-approved medications that we can use to prevent the progression of chronic kidney disease and diabetic kidney disease, like canagliflozin, dapagliflozin, empagliflozin, and finerenone. And we can use, mix and match between them. And I think, to my mind, RAS blockade, sodium glucose transport inhibitor, and GLP-1 will be the main treatment with statin in patients with chronic kidney disease to prevent progression to end-stage kidney disease. So to conclude, we have now mineralocorticoid, new mineralocorticoid antagonist, finerenone, together with the ACE and the ARB, the old medication, sodium glucose transport inhibitor, which are not old anymore, and GLP-1 and the statin. This will act complementary to prevent and to avoid progression. And we can now shift the equation from treating to prevention of development of chronic kidney disease in our diabetic patient. And this, the KDIGO guideline, and we have to work together, diabetologists, cardiologists, and nephrologists, to save our patients' life. Thank you very much.